Hello everyone, myself Dr. Miti Desai, third year resident from Department of Anesthesiology at Nimar Surat, going to talk about my topic which is the study of dexamethasone and dexmedetomidine as adjuvants to local anesthetic mixture in supraclavicular brachial plexus block for upper limb orthopedic surgeries, a prospective randomized study. Regional anesthesia is the safest and the most valuable approach as it avoids the side effects of the general anesthetic drugs and the rest of the other side effects like stress of laryngoscopy, sore throat, nausea, vomiting, and upper airway manipulation. The brachial plexus block can be given through various approaches, but supraclavicular block is given at the site where they are compactly arranged, which leads to adequate pain relief control. And to reduce this dose of the local anesthetic drug in SCB and to prolong the duration of analgesia, adjuvants are added. Commonly used ones are opioids, clonidine, dexamethasone, Maxels, etc. In our study, we have used dexmedetomidine and dexamethasone. The aims of the study were to compare the onset, duration of sensory and motor block along with analgesia when either dexamethasone or dexmedetomidine was added to local anesthetic in low supraclavicular block during upper extremity surgery. This study was conducted in 60 patients for upper limb orthopedic surgeries in Swimmer Hospital. Ethical committee clearance was obtained and the patients were divided into two groups. Group 1, that is dexmedetomidine group, had received injection dexmed 1 microgram per kg plus injection bupivacaine plain 0.5% 15 ml plus injection lignocaine plain 2% 10 ml, total 30 ml solution in supraclavicular block. In other group, which is dexamethasone group, dexamethasone 4 mg, that is 1 ml plus injection bupivacaine 15 ml plus injection lignocaine plain 10 ml, total 30 ml solution in supraclavicular block. These are the inclusion and the exclusion criteria of my study. Parameters studied were the onset of the sensory block, duration of sensory block. Sensory block was assessed with the loss of pinprick sensation, whereas the motor block was assessed with the Bromate scale. Onset of block, duration of motor block, and hemodynamic parameters like mean arterial pressure, pulse rate, respiratory rate, and saturation was recorded at baseline 15, 35, 40, 60, or 120 minutes. At the end of the surgery, patient was kept under observation in the recovery room for vitals. Side effects related to the procedure or to the study drugs were recorded, and duration of analgesia with the help of the first request for the analgesia was recorded through a numeric rating scale. Patients were given injection diclofenac sodium 1.5 mg per kg when NRS score was more than 4. Coming towards the observation and results, age, sex, ASA grading, and weight of the patients were not found to be significant in both the groups on comparison, as well as the duration of surgery was not significant in both the groups. Onset of sensory block was shorter in dexamethasone as compared to dexmedetomidine, whereas duration of sensory block was longer with dexmedetomidine as compared to dexamethasone. Onset of motor block was shorter in dexmed as compared to dexamethasone. Duration of motor block was more with dexmedetomidine as compared to dexamethasone, whereas duration of analgesia was more with dexmedetomidine in total, that is 969 minutes as compared to dexamethasone, which was 840 minutes. These preoperative and intraoperative vitals in both the groups were not found to be significant. Even the post-operative vitals were not considered to be significant. Coming towards the discussion, our current study had showed that this addition of dexmed to bupivacaine in supraclavicular block led to this prolongation of sensory and motor block along with prolongation and duration of analgesia, whereas dexamethasone had led to the shorter onset of sensory and motor block. Dexmedetomidine being selective alpha-2 adrenoreceptor agonist possesses both sedative and analgesic effects which occurs due to the action on the locus coeruleus in CNS. Whereas dexamethasone acts through glucocorticoid receptors which suppresses the ectopic neural discharge and alters some potassium channels which reduce the transmission in unmyelinated C fibers. These mechanisms were explained also by Coram et al. And Biswas D et al. And Hamada et al., Marofer et al., as well as Zhang P et al. Had showed the same results of dexmedetomidine that prolong the quality as well as prolong quality of duration as well as analgesic requirements with no adverse effects. On the other side, dexamethasone was also found to have longer sensory and motor blockade, which was Tandon MN et al., who demonstrated that this dexamethasone prolonged the duration of analgesia. Biradar et al. Also demonstrated a rapid onset of motor and sensory block. Regarding the demographic data, operative characteristic, and hemodynamic parameters, it was not considered to be significant and there were no complications recorded. Coming towards the conclusion, the patients who were undergoing upper limb orthopedic surgeries under supraclavicular plexus block with the addition of perineural dexmedetomidine, that is 1 microgram per kg, to bupivacaine had led to the increase in the duration of analgesia and prolonged the time of the block, but the onset of the sensory block was shorter when dexamethasone was added to bupivacaine. Thank you. These are my references.